Good evening, everyone, and it's an honor. Yeah, yeah. Can you hear me? Yeah. So, good evening, everyone, and it's an absolute honor to presenting my topic in the SAGES, and I want to thank all of you. So, I'll be presenting a readmission score for the acute diverticulitis, and the database that we used, it was a state inpatient database from the HCUP family. So the objective of my talk, it will be, first of all, I'll be starting with the introduction and providing with the background. Then we will go with the methodology, results, then how we created the RAD score, and the limitations and the conclusion of our study. So a little bit background, that the hospital readmissions, they are a significant drain of resources from the United States healthcare system. The US healthcare costs climbed significantly from $260 billion in 1980 to $3 trillion in 2014. And it is estimated that by 2040, the healthcare spending could reach 30% of the total GDP, which is a significant amount of the expenditure. So to address these increased costs of the readmissions, the Federal Affordable Care Act, ACA, it was established in March 2010, and then later on they added the Hospital Readmission Reduction Program, which was effective in 2012. And it required that the Centers for the Medicare and the Medicare Services to reduce the payments and the reimbursements to the hospitals with the excessive readmissions. And initially it was designed for are implemented for the readmissions related to the congestive heart failure, pneumonia, acute myocardial infarction. But then they included the COPD and other surgical procedures as well. So having that idea in the background of the readmissions and how to reduce the readmissions, we thought like we can start a project where we can study the diverticulitis and the readmission of the diverticulitis. So the diverticular disease as a whole, it accounts for more than like 250 inpatient discharge, 250,000 like inpatient discharges, and more than 1.5 million outpatient clinic visits in the States every year. And the annual cost for per hospitalization of the diverticulitis, it's almost around $10,000 to $12,000. And out of all the diverticular disease, 15 to 20% of the patients, they develop acute diverticulitis. So having that background in mind, and with the implementation of the ACA, we thought we can create a nomogram, a predictive nomogram, which can basically assess or give us idea that who are the patients who are at increased risk of readmission, and if we can create a scale that would definitely help the physicians in order to stratify all those patients. So what we used, we used state inpatient database, which is a part of the HCUP family, and we found almost like 145,000 patients. They were admitted for the acute diverticulitis from the New York and California state base. So state inpatient database is basically state-wise. So we use the two states with the highest number of the patients, and we gathered the information of all the demographical features, clinical features, and the clinical pathological features for the 60-day readmission. The cutoff point that we selected was a 60-day. And statistical analysis, we used chi-square, and we used univariate analysis for the binary, using the binary logistic regression, and p-values that we set up, it was like acceptable for less than 0.05. Multivariate logistic regression analysis assess the factors determined to be statistically significant in the univariate analysis, and the odds ratio and 95% confidence intervals were calculated to determine the strength of the association within each group. Then the variables, especially on the multivariate analysis, all the variables who had like an odds ratio of 1.1 or a p-value greater than 0.1, they were significantly associated with the increased risk of readmissions. And using those variables with the odds ratio of 1.1, we use this a nomogram creating formula, which basically gave us the numbers and the scales that we used in our RED scaling system. So what we got, the data of the patients that we got from the HCUP, the SID database, almost like 145,000 patients, almost 16.5, they were readmitted within the 60 days. A majority of the patients, they were younger than 65, Caucasians, had female gender, and had Medicare and Medicaid insurance. And the mean index hospitalization length was 5.7 days. I'm sorry, it's a busy slide. On the multivariate analysis, all of these factors, they were associated with the increased risk of the readmissions, starting from the age, gender, index, readmissions, and all the comorbid features. So by taking all of these factors into the consideration and using the formula, we created a RAD scale for the readmission. And this scale assigns a value to each factor based on its odds ratio. So the higher the odds ratio, the greater the scale would be. So if we see all those variables, the higher odds ratio variables, they have a higher scale and they have a higher point value. So taking all clinical, pathological, socio-economical, and a discharge summary, and the comorbidities, we created a scale with a maximum point based on the odds ratio of 78. Then we had to determine that whether the increase in the score, does it really has an effect on the readmission? And we found that there's a linear regression calculated, which is demonstrated by a 0.36% increase in the readmission with a 1 point increase in the RED scale score. And based on that, the next step that we had after creating the scale, we had to determine a cutoff point where we can say, okay, these are the patients with specific number of the score. They're at low risk, high risk, or they're at moderate risk. So we calculated the RED scale for the admission group and readmission group, and the average RED score was 17.08 for the patients who were not readmitted. And for the patients who were admitted, it was 25. So therefore, our cutoff point, it was like a 17, less than 17 for those patients who are at low risk, 17 to 25 for those patients who are at moderate risk, and more than 25 for those patients who are at higher risk. So this is the criteria that we developed for the readmission of the acute diverticulitis. But there are certain limitations to our criteria, to the score. Number one, the score is not validated yet. We had only New York and California database, so we could not validate it using another set of databases, maybe from like Florida or Washington or any other databases. So that's one of the limitations of the score that we used. The second is that because we used two scores, we cannot generalize our score to all of the population around the world. And the third, the SID inpatient database, it doesn't give us like emergency department or outpatient data, which can definitely and underestimating to overall score that we created. And there's like a potential sampling error and coding error, and because it's a database study, so selection bias is always a component of that. So conclusion, although like it's impossible to eliminate all the acute diverticulitis readmission, the RED score, the scale that we created, it should allow the physicians to implement the risk stratification models. And the implementation of this score, it will reduce the healthcare expenditures based on the proper validation. And further we think that more randomized controlled trials, they are needed in order to further validate the score and to come up with high power studies. Thank you so much.